Hi, everyone. My name is Ann, and I'm the host of Taking Questions on behalf of Women S. And I'm thrilled to again be speaking with Dr. Ekta Kapoor, who is an endocrinologist at the Mayo Clinic. She's an expert in menopause as well as women's sexual health. Thank you so much for joining me again, Dr. Kapoor.
Thank you, Anne. It's a pleasure to join you again.
Can you explain your role as an endocrinologist as it relates to menopause? We'd like our audience here at Women S to understand why it is that we're not just speaking with gynecologists.
Right, that's a very good question. And so endocrinology, as you know, is the study of hormones, right? And menopause is associated with tremendous hormone changes for a woman, which can not only result in very bothersome symptoms, but more importantly, as I see it anyhow, long-term changes in her health as they relate to her heart health, her brain health, and multiple other aspects of her health. So it is a study of change in female hormones. So that's why it ties in very nicely with endocrinology, in addition to gynecology.
A topic we've been talking a lot about here at Women S, and we've also seen in the marketplace, people are talking about menopause and the workplace. What have you learned about its symptoms and how it's affecting women at work? What can women do to help themselves? And the second part is, what can companies be doing to help women who are suffering?
Very, very good question again. And it's really, like you point out, it's a hot topic of discussion currently. So, let me give you a little background. Menopause in general, as you probably recognize, and that's part of the work that you guys at Womaness are doing, it's an under-discussed topic. It's a taboo topic, right? People are not talking about it. So not only are women not talking to each other about it, they're not talking to their doctors about it. And there are multiple reasons that we can go into, but suffice it to say that there is that misconception out there that menopause symptoms are something that are natural, which they are, but that they are to be put up with. They are to be born and just move ahead. So women are not seeking treatment. Now, these symptoms, as we've talked about previously, can be pretty bothersome. Mm-hmm. They can impact the quality of life of a woman significantly. So I think it makes sense if you think about it. If her quality of life is going to be impacted, she's going to be having severe symptoms. There's no way in the world it's not going to impact her professional life, right? Mm-hmm. So the way she functions at work, what she accomplishes, her work productivity goes down. Now, it's a taboo topic socially. It's an even more taboo topic at the workplace because it may be looked upon as someone trying to make excuses, someone trying to get out of work.
Right.
But the fact of the matter is that this is sort of the age, as you can imagine, a woman in her late 40s, early 50s, where she is really climbing up the leadership ladder. And if there is an obstacle thrown in her way, these physical symptoms, it comes at a very critical time when she actually has to give up promotion opportunities and other advancement opportunities and take a hit, take salary cuts, take time off from work. So it can have tremendous implications for the woman herself, tremendous implications for any economy because women make up nearly half the population and menopause is inevitable. Everybody who lives up to that age, any woman will go through menopause. So can you imagine what the economic impact of something like that would be, in the bigger scheme of things? And leave alone the healthcare impact and the healthcare dollars that are spent in managing these symptoms. So what women can really do about it, to answer the first part of your question, is, something you and we've all been doing, that's spreading awareness about the presence of effective treatment for menopause. So just really educating patients so they know what to expect, what the landscape looks like, and seeking treatment, right? But what really also needs to happen at the same time at the workplace, and that's something we are actively trying to change even at our organization, just the supervisors and people who are in the decision-making seats, who have the decision-making ability, they need to recognize that this is a real thing. And then just getting education about the symptoms and, how these patients should be supported through this transition. That education needs to happen also. And, you'll remember this, that all the policies that we have in place with relation to pregnancy and lactation now, having easier access to lactation rooms, for example, that's one of the things that you can draw an example from, that's taken a mindset change, right? We now recognize the importance of that. So the vision really is that in the future, we can treat menopause and its impact in the workplace, look at it the same way, and have policies in place which can help women go through this transition smoothly, because there's a lot of shame, guilt, and embarrassment, sadly, associated with these symptoms. So women do not bring them up because the first thought in their mind is that they will be told, oh, she's just coming up with something and not wanting to do what she needs to do, right? So I think it's a change in mindset that's needed, and patient education, seeking treatment, recognizing there are effective, safe treatments, and the workplace to have that friendly culture where women can actually bring these concerns up.
Making it normal in the workplace.
Yeah,
When
exactly.
we had children, the nursing in the workplace, pumping, doing these things in your office wasn't really discussed when I had children. Now it's something that is just expected. People know it, do it. And I think that you're right. We need to get there with menopause and the menopausal symptoms, and having a place like a room where she can go, and when she's experiencing a hot flash or she had a horrible night's sleep, she might need, a 20-minute nap, that sort of thing. And where they can get help from the medical experts to sort of mitigate these symptoms in the workplace. But having awareness is the first step.
Right. And, like I said, and the important thing to recognize is, and, again, you and I will relate to it, that, especially at our ages, when we are getting to a point that the childcare related responsibilities are not as intense and not drawing as much of our time, and we're really looking at professional advancement and professional growth, this is bang when all this hits us, right? So it is so important to make sure that there's not another thing that's thrown in that timeline and thrown in that mix to make things worse.
Right. It's like we're playing whack-a-mole with everything we have. First it's the children, now it's the menopausal symptoms. I have a lot of questions from our community that I'd like to ask you. One is about chemical-induced menopause and hysterectomy-induced menopause, often at younger ages, and so the median age, younger than the median age of menopause. Is their menopause different? And what should they know about the menopause that they're going to be facing if they've had a hysterectomy?
Yeah, you're hitting all the high points here, things that I'm actively currently working on. So I don't know if it was intentional, probably not. But this is the other area that I'm really actively working on now, is the premature and early menopause, and then why we should treat it differently from natural menopause. I'll speak to that a little bit. So first of all, I want to clarify that just having a hysterectomy, meaning only having your uterus taken out, is technically really not menopause. Menopause is cessation of the function of the ovaries permanently, either through a natural process, which is the natural menopause, or because the ovaries have been taken out surgically, or a woman has received radiation therapy, which has damaged the ovaries, or she's received chemotherapy, which has damaged the ovaries, right? So hysterectomy purely, meaning just the uterus taking out, is cessation of periods, but it's not cessation of ovarian function, if that makes sense. But then again, if we really go into the details of the whole process, sometimes, and women who've just had their uterus taken out, they do tend to go into ovarian failure also a little prematurely, but that's not a universal occurrence. Suffice it to say that purely speaking, even though removal of the uterus results in cessation of periods, it's not really menopause. So I'm thinking what what the person is trying to ask really is menopause due to removal of ovaries. So that's a very good question. So there, the important thing really is the timing of the occurrence. So obviously, if they're asking it this way, it's happening before menopause, but it matters how much before the natural anticipated menopause is it happening. So to put things in perspective, and this is something we've talked about in this show in the past, that the average age of menopause in our continent is 51 to 52 years, in that ballpark. And the age range, the average age range at which menopause occurs, is more like 46 to 55, right? So if a woman attains menopause for any reason, the things that I talked about earlier, ovaries coming out, etc., prior to the age of 40 years, that's the cutoff, that's the magic number, that's considered premature menopause. If she enters menopause between the ages of 40 to 45, that's considered early menopause. Now, the obvious question is why make a big deal? And that's what the question is all about. First thing, obviously, is symptoms. They are pretty much the same symptoms as one would expect after natural menopause. But in some cases, when menopause happens abruptly, they may be more drastic and dramatic. And that makes sense, right? Because if I were to show you like this, through with natural menopause, your hormones are actually going down like this. They may even be doing a little bit of this as they're going down. But with ovaries coming out, one day you have the ovaries, next day you don't. So your hormones from here go down here. So that, this dramatic change can lead to more dramatic symptoms. So pretty much the same symptoms as after natural menopause, which we've talked about in the past, but they may be more dramatic. The other important thing to recognize, Anne, in terms of symptoms is that because these things are happening at a younger age and if they translate to loss of fertility, right? Losing ovarian function, the psychological impact of menopause may be more marked because mainly because of loss of fertility and loss of a sense of femininity, if you will, in these younger patients, that psychological impact may be greater. That's something to be kept in mind. That's something as clinicians we keep in mind, that when we are managing these patients, we have to pay close attention to their mental and emotional health. This is a little different from natural menopause. So when it comes to symptoms, two things to remember. They could be more drastic, more dramatic, and there is a heavier psychological burden. Okay. But, and the bigger issue with premature and early menopause is not just the symptoms, it's the long-term outcomes. Premature loss of estrogen predisposes women to outcomes like increased risk of heart disease, increased risk of cognitive complaints and dementia, osteoporosis, diabetes, and sadly, an increased risk of dying just because of the lack of estrogen. And the younger a woman is, greater is her risk. So when it comes to premature and early menopause, yes, we worry about symptoms and quality of life, but the bigger concern, as you can imagine, really are these long-term changes. That is why one teaching point for patients, and when I'm talking to other doctors also, and I want to make that point very strongly here on your show, is an important take-home message that, this menopause that occurs prematurely and early due to any reason in a younger woman is not just simply an earlier version of natural menopause. It has to be viewed with a very different lens. This is truly what I would call a hormone deficiency state, an endocrine deficiency state, because that estrogen ought to be flowing through the woman's veins till she becomes menopausal. So this is not just natural menopause happening earlier. This is an endocrine deficiency, like not having enough thyroid hormone, for example. So it has to be viewed with a very different lens. That's why I say this is a very good question, because when it comes to hormone therapy use in particular in these patients, it's more like replacement therapy, right? And this point is not well recognized enough. So, I really cannot emphasize this enough, how important this whole issue is, and that such women should be treated with hormone therapy even if they're not having symptoms, if that makes sense, because you're trying to prevent those long-term bad things from happening.
Thank you. I have another question. It's about the birth control pill, and we do get a lot of questions about birth control. This particular question is, I'm in perimenopause and I'm taking the birth control pill. How do I know I've reached menopause if I'm on the pill? I'm still getting light periods, but I'm afraid I won't know what hormonal or menopausal stage I'm in if I'm on it.
Yeah, that's exactly right, and that's a very good point also. Oftentimes, when you are on the birth control pill, you basically do not experience any symptoms of menopause because you're getting these hormones in the birth control pill also. So in these situations, a couple of options exist. If you really want to know whether you're in menopause or not, you can stop the pill and see what happens to your periods. And some patients even request blood work to check that out, and we can do that. But if you stop the pill and the period doesn't come back, or if you start experiencing symptoms of menopause, then you have your answer, right? Now, sometimes though, women are truly using this for contraception. As you know, a lot of times the birth control pill is not being used solely for contraception or for contraception at all. They're using it for regulating their cycles because they're having heavy periods. So depending upon what the goal is, sometimes they don't want to come off of this stuff because they're using it as a contraceptive. In that situation, what we sometimes tell the patient is to continue taking it lower dose estrogen birth control pill till the age of 55. And where does the number 55 come from? I told you that the age range of menopause, normal age range is 46 to 55. So in that age range, there is a theoretical potential to get pregnant. So, when you are approaching menopause, chances of pregnancy are low, very low, but they're not zero. We've had patients who've gotten pregnant, even in that age range. So if the goal is contraception, either you continue till 55 or swap it for a different contraceptive, and that way you can know whether or not the patient is having menopause symptoms. Now, one thing which is sort of a more rare occurrence, but I see it, so I'll mention it. A lot of times, or not a lot of times, but sometimes I will see patients start experiencing menopause symptoms even when they are on the pill. So that's a sign right there that for some reason the birth control pill is not controlling their menopause symptoms. So then I stop it and see what's happening to their cycle and their symptoms.
Mm-hmm. What sort of symptoms, what sort of changes should I expect once I reach menopause and I am officially in postmenopause? Will my perimenopausal symptoms go away? Will there be new symptoms? How do I prepare for them?
Again, a very good question. So the answer is it depends. It's not the same for everybody. A lot of women, as we've talked about before, start experiencing hot flashes and night sweats when they are in perimenopause. And for some, after menopause, they may get better. For some, they may get worse after menopause. Some women may not have any hot flashes or night sweats at all in perimenopause, and they may start for the first time after she becomes menopausal. So that's a very variable trajectory, and there is no way of knowing which path a given woman is going to follow, right? Now, some symptoms do tend to get better once a woman is through that perimenopausal phase, and those would be headaches. Migraine headaches oftentimes will get better. Mood disorders are often the worst, or mood problems are often the worst during the menopause transition. After a woman does become menopausal, they get better. Similarly, cognitive complaints, the brain fog, etc. Sometimes they are more marked in the perimenopausal phase, but they get better after menopause. One symptom that consistently worsens the further a woman is into menopause, you can imagine, is vaginal dryness and discomfort with intimacy. Then sleep is another issue, which may not be as bad in the menopause transition, but continues or becomes worse in the postmenopausal phase. So it really depends on the symptom, but I think the most important thing to remember is that for the majority of them, eventually 7-8 years later, hot flashes will get better, and vaginal dryness for majority will get worse.
We get a lot of questions about breasts. How do your breasts change during menopause?
Yeah, again, another good question. See, breasts are hormone sensitive tissue, right? So they need, as they respond to both estrogen and progesterone in slightly different ways. But then when you have loss of these hormones with menopause, there is basically loss of breast tissue cells and more presence of greater amounts of fat in the breast, and the breast can sort of become sagging in nature. So in a sense, they are shrinking because of loss of tissue, but with all the fat and the weight gain, etc., they may appear to be large and sagging also. And the risk for breast cancer goes up with age. So postmenopausal women, for that reason, tend to have a higher risk of breast cancer.
We talked about vaginal dryness, and are there treatments if you're suffering from vaginal atrophy?
Yes, some very effective and safe treatments. So the first tier of treatment really is vaginal lubrication and moisturizing. Lubrication is to be used before intimacy. It is for the act itself. Moisturizing is like moisturizing any other part of your body. So you do it on a regular basis, independent of sexual activity. That's sort of the first tier approach we use for vaginal dryness. If it's not effective, which usually is the case over a period of time, as I was telling you earlier, Anne. So then vaginal estrogen available in several different types of formulations, cream, tablets, etc. Very effective, very safe. Again, the important message there is that the safety profile is not the same as it would be like, for example, using an estrogen pill or a patch. This is local estrogen for the genital tissues, and it is safe for long-term use.
So if you're not able to use the creams, there is a pill available to you
There
that
is
you can use.
And gels and things like that. So there are a lot of different types of formulations of vaginal estrogen. So it's a matter of discussion with your healthcare provider, depending upon your medical history, your preference, your insurance provider. So those are the factors that go into decision making.
I have a question from someone who has chronic joint pain literally everywhere, wrists, knees, shoulders, hips, ankles. And on top of that, she's gaining weight. What can she do to relieve the pain that she's feeling so she can start exercising again?
And this is all new in the context of menopause?
Yes.
Okay. So yeah, there is an entity called menopause arthralgia, meaning all these aches and pains are occurring purely due to the hormonal changes of menopause. But what I always say is that there are other conditions that can cause joint pains that are also common in midlife women. So talking to your healthcare provider about it would be important to make sure there are not other things like, it may be just a sense of overall achiness. Let's make sure it's not anemia. Let's make sure it's not thyroid dysfunction. Then it will be very important to see how she's sleeping, because lack of sleep night after night can manifest as just that sense of fatigue and achiness. Fibromyalgia is a common condition that shows up in midlife women, and that is also the hallmark is poor sleep and joint aches and pains. But if none of these factors are at play, then yes, we can say that this is menopause-related arthralgia. Ironically enough, the management for that would be a graded exercise program. But then again, if she's having other symptoms of menopause like hot flashes and night sweats, which might warrant use of hormone therapy or other treatment for those, then treating them might help the joint aches and pains also. So basically, there could be several different causes for it. So talking to your healthcare provider and getting the detailed evaluation would be very important.
The next question is, I'm 48 years old and I'm in perimenopause. I have several large fibroids. Will they shrink on their own once I go through menopause?
Yeah, they likely will, because fibroid tissue is very sensitive to estrogen. But then again, it also depends. The management depends on what your symptoms are right now, because like we've talked previously, the duration of perimenopause can be highly variable. For some women, they can last for years and years. So if these fibroids are now symptomatic, either they're causing you to have a lot of bleeding, which can put you into anemia, or you're having mechanical symptoms. So it's not easy to just hang our hat on the fact that eventually they'll get better, because we don't know when that eventually will be. So I think the management really has to be dictated by how bad are the symptoms right now. So if these are decent sized fibroids and are causing symptoms, then something probably ought to be done about them. So again, it can be a nuanced discussion. So discussing with healthcare provider would be very important.
Someone just asked me recently in the after party about hot flashes. She was having relations with her husband and she got very, very hot, but she wasn't sweating. And she felt this flash come on, but without the perspiration. Can you have a hot flash without actually perspiring?
Oh, yes, absolutely. It's possible.
There's all these wonderful symptoms and all these different variations on the symptoms. But
yeah,
but
it's possible.
the answer is yes. And then the last question that I have for you, and this is an interesting one, is there such a thing as male menopause?
Their hormone levels, the main reproductive hormone, testosterone, that does go down as they get older, but there is no such thing like we experience one event, or it's not even one event, but a time period when the ovarian function just stops. That there is no parallel for that in men, no.
Okay.
But slowly their hormone levels do go down with time.
I have one more last one, and it's actually a topic that's near and dear to my heart: alcohol and caffeine in menopause. Do you need to cut back? Do you need to change? What is the relationship with alcohol and caffeine in menopause?
Very, very good question. Alcohol has really come to the forefront more in the recent times, months, and I don't know if you've sort of been following that, Anne, but previously it used to be just alcohol discussion really in relation to hot flashes, right, after menopause, and then some cancer risk, etc. But then and heart health and weight, and then but we would say that having that one glass of wine a night was probably still okay. It was good for your heart. In the recent times, we're moving away from that. And the main reason for that is the increasing recognition of the association of alcohol with two important cancers. One is breast cancer, which obviously, with me being a women's health provider, is near and dear to me to counsel my patients about. And the second is colon cancer. So, both pretty common cancers in the US. And the data is pretty strong, and it points out that any alcohol use is linked to cancer risk. So I am telling my patients now that cut back on alcohol as much as possible. Now, this is a very personal decision, obviously, and there are patients who feel very passionately about this. So obviously, nothing can be said very dogmatically in that respect, but this has become a very important counseling point for me. And when I tell patients about the breast cancer risk with alcohol use, it comes as a surprise to many of them. So they know about other health risks associated with alcohol, but breast cancer, somehow I always get their attention, their jaw drops, and they're like, oh, really? Like, yeah. And then, you can talk to people about the effect of alcohol on weight, and you can talk about the other problems. But when you mention the word breast cancer, it scares women. It really does. And we know why it does, right? It's a common cancer, it's a bad cancer. So somehow I really, really get my patients' attention when I mention this association. And they're more, the ones who are drinking excessively or even moderate amounts are more inclined and motivated to cut back after learning of this association. So that's where alcohol is. So, the whole thing about the worry of alcohol and hot flashes and that association, for me personally, that has fallen on the back burner now. My bigger thing is, my bigger thing now is breast cancer risk, and I am an obesity doctor also. So the weight aspect of it, those would be my big things. Caffeine, the thing is, excessive use can result in worse hot flashes for sure. And that's one thing. But this is like really excessive use. So not those 2-3 cups a day. I'm not going to do that for you. The thing with caffeine use also is that there has traditionally been concern about worsening bone health, lower bone density, osteoporosis, etc. That literature, I think, what the main message there is that when you substitute um, um, the calcium-rich beverages by caffeine, for example, which is not your latte, for example, which is rich in milk, then you are not getting enough calcium in your diet to protect your bones. But then again, as you probably know, the whole literature on calcium and vitamin D and bone health is also somewhat mixed there. So yes, there is a concern with respect to bone health. But I think the bigger issue for some patients ends up being the hot flashes associated with caffeine. But it's not the same association for everybody. Not everybody has the same sensitivity level. So I just tell people to listen to your body. So, because you see all sorts of use of these things by patients. I once had someone who was drinking like 16 cups a day. So basically, one cup every waking hour, right? Something like that.
Right.
There, and she was having bad hot flashes. I was like, okay, I think it may make sense to cut back on that and see what happens. But those traditional 2-3 cups, if somebody is having bad hot flashes, I don't know that cutting back caffeine really helps. I ask them to try it anyhow, but I'm not very particular that, somebody should be cutting back any further if they're at that level already. So that's kind of my take on caffeine.
Great. Well, thank you so much.
One more thing, and caffeine, depending upon where they're getting it from. If they're getting it from soda, that's a different ball game, because the acid content there and diet soda, as we are learning more and more, can be so bad. So I'm talking people out of drinking diet soda all the time. That, if you must have soda, make it occasional, but have a regular soda. Do not go towards that diet soda. That is bad stuff.
For sure. I just gave up soda 2 weeks ago, and I've switched to unsweetened iced tea.
Good for you, man.
So the first week was really, really hard. Now I'm getting used to it, and I've also given up the sugar in my coffee.
Oh,
so 2 weeks on that too, and I'm doing okay. Someone said you enjoy the notes of the coffee more if you don't have so much sugar in it. So I'm trying.
You are
baby steps. So, but thank you so much for your time. I always enjoy our conversations. And on behalf of Women-S, we appreciate everything that you are doing for women. This is a journey and we are all in it together.
I know, and I'm very passionate about this. It's always a pleasure to be here and talking to your audience, because that's, like we've talked in the past, our big goal as women's health providers, to really educate and empower our patients. Because I think at the end of the day, they will change the landscape more than the providers can. Because if they go to their providers empowered and with all that information, I think they will seek the right answers, they will seek the right treatment, and we will be able to put things on a good track.
Well, thank you, Dr. Kapoor.
Pleasure, Anne. Take care. Have a good day.